Thank you, Professor Ahmed, for allowing me to give a talk today on telemedicine. I've been studying telemedicine for about 10 years, so it's really great that finally we're actually getting into a world where it's becoming norm. I hope you're all well. I hope this isn't sort of the last talk of the day. I don't want you to get really tired and then have to sit through the next 20 minutes with me. But what I'd like to do is perhaps give you an idea of what to expect when it comes to telemedicine and your future as clinicians. There's a lot that you need to understand around the safety and how we work. There's a lot you need to understand of what you can do, because that's the trivia nowadays that people are facing. What can you do? What can't you do? And some of it's about just understanding how it fits into our daily lives, because ultimately the clinician of the future is a hybrid of everything you see. It's a bit of this, a bit of XR, AR, AI, and it's also a little bit about how we do the face-to-face consultations that we're traditionally used to. Medical schools, hospitals, clinics, we've all been far behind with technology for a long time. It took a pandemic for us to change, and that's both sad, but good in some ways, because at least we've moved at pace. We've kind of gone the other way. Everything's become all about virtual video telephone. And we need to kind of mix the two together and find out what the right playing field is. So you are the future of clinical care in the digital world. And I think because you've grown up with the technology, you're probably a little bit more used to it than some of us. And certainly I'm a big fan of technology that we use every day, becoming part of healthcare journeys. So just to kick off, I'm going to give you a little bit of information around telemedicine and virtual health. So my name is Mateen Jiwani. I'm a GP by background. I've been currently involved in a number of different spheres across the globe, teaching around telemedicine safety, but also what it takes to actually become an organization that's digital first. So how do you become this place where technology is the very key of everything we do? I think I always start with this slide because it's really important. I think all of you will understand this slide without me saying much. You can tell what's going on. It's essentially just telling you about the digital world and the social media world. And this is how we live, right? This is what we do. We take pictures to communicate, we take videos, we FaceTime, we WhatsApp video, WhatsApp talk. We are always moving with technology to allow us to live our daily lives in a better way. So why are we not doing that with healthcare? I mean, it's just another part of the journey, right? Most often people get worried about safety and governance, and I'll touch base on that later, but the truth is they're not as big an obstacle as we think. The future of how we work is all about what we do in our daily lives. So at this point, I always give an example of Sainsbury's. I think it's great, during the pandemic, they very quickly implemented the scan app on your phone. You scan everything you do, you put it in the bags before you get out, you pay very quickly. Within a second, your whole transaction's complete. The good thing about that was it relied on people just doing things. And in that industry, people were saying, well, what if someone steals? And they worked out very quickly that the chances of that happening were so small, and probably the same as what was happening when you did everything face to face, that actually it didn't make much of a difference. And now it's become a really big part of society. It's a normality of how we work. So everything you do, just think, why is it not adapted in healthcare? There'll be lots of other examples you can think of. Education and healthcare have always been struggling with the concept of reality. They've always said, well, actually the reality is all physical, but perhaps there's a virtual one too. And that's going to be a new way of us moving forward. And you've seen some of the talks already and some to come around technology and virtual reality and augmented work. That is all going to change the very way that we're going to interact with each other, a bit like today, me not being there in person. So the objectives are, I'm going to tell you what virtual medicine or telemedicine is. I'm going to tell you what's happening across the globe and what's the likelihood of us doing things. So telemedicine started a very long time ago. It didn't start now. Just be really clear about how history worked with physicians. And way back, Mesopotamian eras, we knew medicine existed because people used to help each other when they were having trouble with ailments and herbal remedies and so on. And then things kind of became very much around talking to a local or tribal practitioner or someone local who happened to have all knowledge and gave you information. The Egyptians had moved into sort of examining and understanding, so examining corpses, what happens, what's the change, retrospectively labeling people with disease processes or what we call diseases now. Of course, there's the Ayurvedic medicine movement from India, and then China and moving around, we've always been people who went to someone, talked about something, were given something, and then in return, that was your physical interaction. For the very first time, we take the patient away from everybody and they're not in the room anymore. So what does that mean for a clinician? Because all our teaching is based on people coming in, talking, prod and a pro, and then we do something and give them something in return. Now the patient's not there anymore. It just changes the fundamentals of medicine. How do you work? What are you planning to do? When you walk around throughout your wards, a lot of you will be doing ward placements, hopefully starting up again soon. And what you'll find is there's some key problems. Sometimes patients can't see the doctors or the nurses or the practitioner quick enough. There's problems with people getting multiple conditions. We're better at diagnosing things, but now that means people suffer more things. And then sometimes it's about, where do you go to get the help? You can't get an appointment with a GP, right? Everybody knows that. You just can't. They're working flat out. The A&Es are around. Everybody says you have to wait hours and hours in A&E because they're busy too. Can't get an appointment with your consultant. You have to wait till, I think the patient said to me, I've got an appointment for my consultant. And cheek and tongue, she said, it's in 2023. And I said, yes, but routine things will take time because everybody's flat out at the moment. And then there's this other thing, about people having to go and meet and talk and traveling to places, and doctors and nurses, we all have to run around and go to home visits, and then we're doing meetings in places. Well, virtual is a huge cost saver with all of this. And perhaps, just perhaps, it can answer many of these questions for you. So what's changed? The bit I told you, people used to come to doctors and they're not anymore. Examining person was key to actually finding an answer. And that might still be true, but actually in the first place, we can make lots more differentials before they get to us. Traditional teaching is completely changed. So we're going to have to learn how to do more clinical work over telemedicine. And that's going to require a whole change in thinking. Education itself is going to be upside down for a little while. But telemedicine has been around because people across the waters in Australia and New Zealand who've been doing hundreds of thousands of telemedicine consultations over the years, even millions in some cases. They've been always having to work in rural areas. Now they can't travel up and down mountains within hours. So they've had to use telemedicine through people traveling by helicopter and then coming back. And they have great data to say, look, we worked out what you could do is you could do the initial part. You could do a lot of initial triage, and triage, not the conventional way of saying, have you got a cough or a cold or chest pain or allergies, but really detailed triage so that you can make a good decision and you can decide that they might have early treatment and then come back in for more focused treatment and a focused diagnosis. And we should learn from that. Through time, the way the word tele has worked is it's kind of communicated in different ways. And we can see through public health agendas, wartime era, where we've had broadcast to everyone about public health messages. That's a form of telemedicine. We've had computers where people have communicated like scans and x-rays. That's telemedicine. We've had video conferencing back in the 90s, started off with businesses doing things. And then we use that as a way of communicating with other clinicians across the globe. That's telemedicine. We've even now moved forward into VR, AR, AI, where we're actually communicating in avatar or holographic forms. That's telemedicine. And then we've got online consultations where there's chatbots and symptom checkers, and that is telemedicine. So what's happened is the definition has become a bit skewed. So that's why I call it virtual medicine and virtual health, because I think that's a bit more sensible and easy to understand. But ultimately, it's about how we use technology and we stop disease, or we prevent it from happening, and we start to treat early, and we do some research and evaluation behind that. And then it is about how we communicate that openly and make it accessible to the whole community around us to fade out health inequality. So where's it used? We know it's used by your GPs. You've probably seen them. Most of you have had some communication. I wouldn't say it's used every day. I think they're still trying to understand it, but we know that facilities there and GPs and nurses in the community have started using video. We know mental health practitioners are using it. We know hospital care is being used specifically for follow-ups. And then we know that there are certain surgical ward rounds being done by robot telemedicine as well, where people are coming in. So specialists may be in 2 places at once, but they can offer that information on a ward round through these robotic things. And certainly in the Royal London Hospital, there's some forms of that happening, and Sheffield was one of the first few who tested that out. Emergency workers have been using it for stroke assessment, so whether someone should get treatment immediately or whether they need to be moved into another specialist care area. So definitely, you can see in that picture at the bottom, this is the sort of thing where the doctor and the clinician is trying to assess whether the patient should have treatment at that point. So typically what's happened is you've had the patient, and then you've had professionals sitting outside, so other health members. Then you've got the clinician who's focused with the patient. So they have a relationship, and this doctor has a relationship with other members, or this practitioner has a relationship with other members. This person only has a one-way communication. And that means that people haven't traditionally been involved in their care very much. It's we talk to our colleagues, and then we talk to the patient, and that's the way it usually happens. And we might ask one of our colleagues to call the patient, but the patient can't interact with anybody else other than me, which has always been a bit of a problem because it's slowed down how people access care. So advantages of doing virtual is very simple, and most of you will know this, right? You can see someone, that's a bit better than listening to them on audio. You can manage your time better, so there's less people traveling around, walking around. There's something weird about video as well. What I've learned through research is people stick to time. So when you have them in a room talking to you, they'll spend 20 minutes, 30 minutes with you. But on video, it seems people just, all that chit chat's gone. It's like a very focused conversation with a very little social element. So people tend to be quicker about their problems, which is a fascinating area. I mean, in general practice, I found that there are at least 3 minutes saved per consultation. And that was over doing several hundred. So that's a huge number when you think about it. And that means more people will get appointments in return. So very, very fascinating advantages. But here's the thing you need to be careful about virtual health: safety. Like, are you going to do everything? Are you going to be the person who's going to examine everything on video and take a punt? Or are you the person who's going to be a little bit cautious because there is very limited evidence around it? So safety is paramount. Things about people being in the room who can listen, what to do. And some of that we've been building courses around recently. Emergencies, how do you rule them out? Well, online symptom checkers have done a good job of that. So I think there's just a bit of learning, and we could do that probably again. Examinations, same thing. What can you do? What can't you do? There's new technology always. That allows us to examine better. So we should be moving into that soon. The triage element we talked about, the environment, we talked about safety and security. And then, of course, how safe are you to start treatment on virtual health? What can you do without causing too much harm to the patient? Notice to say causing too much harm, because I think ultimately whatever decisions we make, they're not always safe in virtual. It's about taking the benefits versus the risks and figuring out what we can do. Don't ever forget, we have an oath to stick by. It says do no harm. Ultimately, everything we do will have an element of harm involved with it. Every medicine you give has a side effect. We weigh up the benefits, and in our head, we're doing as little or as close to no harm as possible. This is what the new doctor's bag look like. It should look like. You've got things that attach to your phones, things that patients can keep, things that you can check, data that's coming in, and you can probably do all of this. And so the traditional tools that you use, whilst they're still useful, will start to go out of fashion over the next decade or two, because I think as technology gets better, you can probably get more data from some of this equipment. And some of this is fascinating, and already the research has been incredible. So who's been doing virtual and what's been happening out there? Let's think about the startup world, right? That's the exciting one. Everybody's making stuff. Everybody's out there selling, doing, inventing, and it's crazy. Well, some people have done some amazing things. So Babylon, we know, started off doing video work, very much funded around doing private care initially. They now do a little bit of NHS, but they're moving across the globe doing more virtual care. So they start off with a sort of chatbot, and then you can access a doctor by video. Doctor Care Anywhere, this company did really well, and they've basically been doing stuff at the workplace. So healthcare has moved not just from you coming to it, but they now go to places where people work and look after them. And that's been a huge success, all done by video, all done to help the patient understand the early intervention of illness. Heal is the equivalent of some of the telemedicine players in the UK. They are a home visiting and telemedicine platform. They basically do everything at home. They will try and diagnose and treat as much as they can, and then move on to specialists because they're mainly American-based. And then Sehat Kahani is a new startup that was based in Pakistan. It's a fascinating story backed by Microsoft now, where they've said they noticed that they had a whole bunch of clinicians at home who were qualified doctors, who then typically were female, got married, and didn't continue working because they weren't the main breadwinner. And they thought, hang on, we can surely get them to offer some service to the public. So they started teaching them video telehealth medicine, and they gave them laptops and said, look, we're going to get people to talk to you through their smartphones and so on. Can you help those who are struggling in communities? And this has made a huge difference, especially for female patients where they've been traditionally not necessarily approaching healthcare practitioners because of gender. This has made a huge difference to that population, and it's a story that's fascinating to continue knowing about. So how are we going to work eventually? We're going to start moving into a two-way dialogue with everyone instead of a one-way dialogue, and things will change. And what will happen is the healthcare practitioner will not just be talking to other professionals, they'll have someone for support who will be tipping into the patient all the time. So link workers, key workers who are mental health specialists, nurses, healthcare assistants, pharmacists, physician associates, everyone will start to tap into the patient with the main practitioner who will have overall responsibility. And so we'll work a lot closely together. Your OSCEs will change, if not already, and some of you have already gone through a new examination phase by push because of the pandemic, but this will all become normal. You'll be taught how to do telemedicine, one hopes, and then you'll be examined on what your telemedicine skills are like. The future gets even more complicated as we start to have new devices give us new information. We know that there's a watch that's been patented recently that's going to have blood pressure on it. So we need to do the evidence around the accuracies, and then what can we do with that data, because people won't need to come in anymore. Ambulatory blood pressure readings, where we give them monitors and things, will become obsolete, and we'll be able to get data real time in thousands of bits that will come through. So having systems that can read that data will be really important to give us the information we require to make decisions. Anatomy teaching has changed already in many schools, where you're able to do virtual cadavers, examinations for simulation, and then of course learning when you're not there, so virtual environments. And Shafi's been pretty much the main leader around this, about making sure people can learn from the operating theatre while they're not there. You can see these robotic ward rounds, people doing virtual assessment. You can see here, they're looking into the mouth of the child, but the clinician is actually looking at the video and making a diagnosis. And these tools are more complicated, but actually the future of what we do. And so as we move remotely across the world, we'll be able to do this work in detail through virtual platforms, and all that data will give us the ability to make diagnoses and decisions. And the senior clinicians will become ever more important, because as they are becoming more and more rare, the junior teams, and by that I mean anyone and everyone ranking all the way up to GPs and consultants, will be feeding into their expert colleagues to get that information out. AI, of course, you know about, I won't dwell on that, but basically it's about how this information then gets computerized and learned itself, so that we have to stop thinking about what the next potential algorithm or pattern could be, and it would recognize things much earlier for us. This is a fantastic new sort of startup, I would say, maybe a bit more than that now as a business, but they basically can work out by videoing through someone at home who from their iPad will make movements. We can tell from their movements how good their joints are, what the injury is, just by their movements of flexion, extension, abduction, adduction, by doing exercises. So all those little things you have to remember about musculoskeletal will become a thing of the past, because things like this will tell you how many degrees of deflection there is in the injury, and you could work out and diagnose exactly where the muscular strain is coming from. And then you can make early adjustments to people's home physiotherapy, and you can start to see how this will become physiotherapy at home, and very little will be needed to be done on site. Some of the work we're doing now is across Nepal, and this is a team I'm involved in, and we're building clinics with computers in. And then what we're doing is trying to remotely get people, clinicians in India, and otherwise, who are going to tap in and tell pharmacists and local practitioners how to do assessments. And they're going to take that information and give them a treatment plan for them to be able to do, because rural areas like this take days to walk. So I think that village you can see at the bottom here, the road stops and there's a good days up and down the mountain walk to get to the place that we need to. So this is the future of helping the countries that need it, not just here. And it's about the people that are really suffering, that could have done with this telemedicine years ago. And perhaps now, if we're willing to take it on and learn from it and use it, then we'll be able to do that with some of these more deprived individuals. And then, of course, mental health has been moving forward with biometrics, learning how to recognize facial patterns. We'll be able to tell cues that we miss. So when someone's feeling sad and you haven't quite picked it up, the computer will tell you, I can read that this person isn't feeling great. Maybe ask them the question, it will prompt you about certain things you should be asking. And chatbots we've talked about. So research and development is happening all the time. If you're interested and you want to do more, if you want to get involved in some writing or perhaps just some presenting articles or whatever it is, I'm always involved in doing things, and my colleagues likewise in the Imperial faculty. So if you're interested, more than happy to get you involved. It's all about working together now. So give me a shout on the email. That's my Twitter handle. I look forward to speaking to you all, and thank you very much for your time today. Good luck with the rest of the day. Thanks, Shafi and team. Speak soon. Bye now.